Hello and welcome everyone. Today we are doing the weekly review of the last week's literature. The first study is the next gen sequencing in the diagnosis and help in severe community acquired pneumonia. The research question here is the impact of next gen sequencing of the bronchoalveolar fluid on clinical outcomes in ICU patients with severe community acquired pneumonia. It's a multi-center randomized open label trial in 10 ICUs. The patient were randomized 1:1 into the next gen sequencing versus conventional microbiology. The primary outcome here was the time to clinical improvement based on the ordinal scales. The result was 349 patients were randomized and 170 in the conventional and 179 in the next gen. It's an intention to treat analysis. They found the time to clinical improvement was 10 days in the next gen and 13 in the conventional. The difference was 2 days. And per protocol also showed us similar results. Clinical improvement within 14 days, the next gen had 62%, while the conventional had 46.5%. And though in the secondary outcomes, they did not find any significant differences. But the conclusion is definitely that the next gen sequencing is better than conventional and is definitely improving in terms of the clinical improvement as well. The next is the physiotherapy study on the inspiratory muscle training. We all know that inspiratory muscle training is important and needed to reduce the ventilator durations. So the hypothesis here was that a mixed intensity program for both endurance as well as strength could be more effective in improving the function of the inspiratory muscles. So it was a multi-center randomized controlled parallel trial, 92 patients, three groups. They had a low intensity, a high intensity, and a mixed intensity group. And training was given twice daily, 7 days a week until the patient was extubated, or 30 days was the primary outcome though was maximal inspiratory pressure increase. Secondary, there were various outcomes. Coming to the results, the mean inspiratory pressure increase was 10.8 in the mixed group, 4.5 in the low intensity, and 6.7 in the high intensity. No significant difference between the mixed and the low intensity. No significant difference between the mixed and the high intensity. Though there are significant, means the values appear high, because of the low population, we don't see any significance. Weaning success was similar between the two groups, and no significant difference in other outcomes were seen. Regarding the safety, it was all very safe, other than there were some episodes of bradycardia in the low intensity group. Regarding the conclusion, we obviously didn't find anything significant, but this thing appears to be safe and well tolerated. The only thing we need to look for is the cardiac side effects, probably of the strength and endurance training. But because it was a very small trial, we did not find much of a difference. The next is Alfentanil versus fentanyl in rapid sequence intubation with ketamine in emergency. Fentanyl is something which is commonly used. Alfentanil with more rapid action is thought to be probably more suited for rapid sequence intubation. It was a double-blind RCT in Australia with 3 emergency departments. Adult patients were included, and the patients were randomized into 2 groups. The measurements was basically they did all the hemodynamic monitoring, the primary outcome being systolic blood pressure. Secondary outcome were all the various outcomes. And if you look at the results, again 61 patients, less patients, 30 in each group, 31 in alfentanil. 58% of the patients with alfentanil had the primary outcome, that is they were within the range, and the difference was 8%, and secondary outcomes were similar in the two groups. There was not much difference, at least no statistical difference. So as you can see, most of them are similar, and both alfentanil and fentanyl showed comparable hemodynamic results and intubating conditions along with ketamine. So alfentanil appears to be okay and similar to fentanyl, but probably a non-inferiority study should have been done over here, and we need more patients over here as well. This too small a trial. So the next is 5 sessions of hyperbaric oxygen in COVID-19. We all know that COVID-19, the treatments are very limited, so they tried hyperbaric oxygen and they were seeing if it has any improvements. So it was an open label with 3 hospitals in Sweden and Germany. The patients with moderate to severe ARDS and risk factors for unfavorable outcome were used. Mind you, these are not really intubated patients, they just have moderate to severe ARDS. So the intervention was the hyperbaric oxygen was 100% with 2.4 atmospheric pressures for 80 minutes, 5 sessions within 7 days. This was the intervention, and control was what is commonly done, randomized based on stratified based on sex and site, and primary endpoint was ICU admission by day 30. There were other secondary outcomes like mortality and time to intubation. Coming to the results, 34 patients, very small. Primary outcome was again 50% for the control, 72% for the hyperbaric oxygen, though it's not statistically significant. Secondary outcomes were again slightly better with the control group, but again not statistically significant, no significant difference in the other parameters as well. Inflammatory response was significantly decreased, that is CRP was less in the hyperbaric oxygen group. But the safety was there were 102 adverse effects, and severe adverse effects were more with the hyperbaric oxygen, like pneumomediastinum and pneumothorax. No negative effects on the staffs for the hyperbaric component. But the conclusion is that the hyperbaric obviously did not have any impact on the outcomes, and the trial was terminated prematurely for futility for obvious reasons. In future, if we have more funds, probably can try this, but doesn't appear to help. The next is high PEEP and low PEEP in general anesthesia patients. This was a meta-analysis. We directly jump into the results. In this, they did a Bayesian analysis of the individual. I won't be going into the details of this stat findings, but overall, there was no major difference in terms of the findings that they had in terms of the prior versus the post probability. One thing that was clearly established was that giving high PEEP was beneficial in preventing post operative pulmonary complications. So high PEEP should be preferred, especially in laparoscopic and high risk patients. Regarding the ultrasound in gastric tube placement, this was again a meta-analysis where they looked whether ultrasound can be given for confirming the placement of the gastric tube. So this was the basic objective, and they searched all the literature, basically updated the Cochrane database up till the April 2023, and they looked for also the X-ray and the method that's air insertion and all that we do, and they compared basically that. And in this, they collected the data, and 2 reviewers did all the analysis and everything, and they used a random effect logistic regression. 12 studies and 1,900 patients were included. The risk bias was very low over here. If you look in terms of the sensitivity for these things, this is with the echo window are pretty high, and this is echo window without the injections. This is also pretty high. Regarding the specificity was very low because the population was very small. Ultrasound alone though had a very less chance of specificity, but if we combine it with the injection and all, it has a pretty good sensitivity. Final study is the methylene blue in septic shock. They looked at the role of methylene blue and its role in septic shock. They compared the 6 databases. They included most of the RCTs, and again the 2 reviewers were doing all the analysis, and various stats were put. So the bottom line is 6 RCTs, 302 patients. They were looked at the various efficacy outcomes, and then they found that it was showing benefit in almost all the parameters, but obviously with a very low certainty. Adverse effects were very less, so if you think you can use it, but this is a very small population, this meta-analysis doesn't change much. There is very low certainty that you will get a benefit. So what we need is a very large trial, probably a multicentric RCT, to give us more proper information. Thank you for your patience.